Welcome to episode 2 of the Info Snacks podcast with myself, Ben Cormack. And by popular demand or just a simple poll on Insta, we are going to talk about why is my patient not getting better. Of course, the idea of the Info Snack is it takes 15, 20 minutes, maybe even less, to talk about some of this stuff so you don't get bored, you don't start reading a book or flicking through social media, etc. I have your undivided attention. All right, so the idea is, why is my patient not getting better? And I think that's something important. Let's start out with two things. So the first thing is the idea of a prognosis, or what is the likely course of this problem? How long is this going to take? What's likely to be the outcome, etc. And then also the idea of how much does a treatment actually help, and we get that from research trials, etc. So let's start with the idea of prognosis, and we're going to come on to prognostic factors. A prognosis would be a general idea of what's going to happen, and that might take into account a number of different factors, which would be the prognostic factors we're going to talk about, and things like natural history, whereby we see the kind of natural course of a problem if it's untreated, for example. So, the prognosis for most musculoskeletal problems is it will get better in a specific time frame. And that's going to be affected by a number of factors. And that's something that we can use certainly to guide us. But we have to also think about the idea of the individual within the average or the generality. And so a lot of the things that we are talking about are quite general. So a frozen shoulder might take a year to get better. For some people, it might be 8 months. For other people, it might be as long as 7 years. There's been some kind of documented cases of that happening. So back pain may recover in a few days or even a few weeks. But if we look at a lot of the trials that look at chronic long-term back pain, we're talking months, maybe even years that people have had this back pain going on for. That may not be consistent the whole way through. We know that it has a kind of specific trajectory path, but certainly people who have had this time frame a lot longer than generally an average prognosis would tell us. And we also have this idea, and this comes from things like evidence-based medicine, that a treatment will have a certain effect on people. So again, this idea of averages and individuals. So we get all of these averages that we can say, this may be reflective of the average, but some patients are going to do better and some patients are going to do worse. And why does that happen? So let's think about evidence and research, because I think in an evidence-based world society that we're now in the kind of rehab MSK space, we like to use these type of things to guide us. And sometimes taking a randomized controlled trial, taking some evidence, really doesn't reflect the person in front of us. So the power of the RCT, or the randomized controlled trial, is that we can do things like randomize and reduce bias. Meaning we can take some of the bias out of research, which is the point of research to some degree. Otherwise, we just let bias run wild. And then the second part of it is that we can compare different treatments. So we take two groups of people, randomize into each group, and then we have two groups that we can compare against each other. So two lots of averages that we can compare against each other. And obviously that is a much easier comparison to make than taking all of these different individuals, comparing them against each other, and that information is going to give us very little. So comparison of the group to the individual is probably much more powerful than comparison of the individual to the group. All right. So I think that's a really important, powerful thing. So we could say on average, treatment A has this much effect versus treatment B, right? That is an average based on the population that you are studying. That doesn't tell us what is going on to the individual in front of us. When we randomize, we often end up with equal baselines on average. And that's, again, it shows that randomization is good if we have equality in baseline, whether it's age, height, weight, length of pain, all of these other factors, that information that we may take. But the baseline of the individual that we are working with may not be reflected by the average baseline of the group. All right, so that's really, really important. And this brings us to the huge point of, this is one of the big problems we have with research, is it's taking that information and using it with the individual. So let's take the average effect. So let's say the effect is 1.8 on a 11-point VAS, and we are going to say that's the difference between these two groups. All right, and we could take one patient with a baseline of 8 out of 10 pain and they get 1.8 pain relief. We take another patient with 4 out of 10 baseline and they get 1.8 relief from that problem, if that was the way things that worked. And if you think about that percentage of change would be much greater and probably much more noticeable for that person with 4 than maybe it could potentially be for that person with 8 baseline. And that person with 8 baseline would still have 6 out of 10 pain, or 6.2, whereas the person with 4 out of 10 is going to go down to 2.2, so their pain is going to be almost halved, whereas we'd probably take about 25% off the pain of that person with 8 out of 10. So even the pain baseline for the individual is going to have a bearing on the average amount of relief, if that's the way that these things worked. But of course, that isn't always the way that these things work. Some people can have miraculous responses to treatment, or changes, or outcomes, whatever you want to call it. Again, we can't always suggest that change that we see is totally due to the treatment itself, because there are so many factors that can influence it. However, over the entire course of an outcome time frame that they use in a study, about 50% they discuss being due to that kind of just effect of time and natural history. About 30% is the specificity of the treatment, and about 20% is kind of contextual, etc. But the outcomes that people have, we don't always know why. And I think that's really important. We don't know how much of that is due to treatment or due to time or any of these things. We can only hypothesize. So why do some people get better? Why do some people get worse? Why does nothing happen? For some people, well, I think it comes down to this prognostic factors element, that we have research that I think is really powerful, that does help us understand some of these factors that might influence whether someone recovers a little bit more or a little bit less. And I think that's really important. So that's exactly why we need to, have a good clinical conversation, good communication, because we'd like to know, is this person more likely to get better or less likely to get better? So if you have a patient who is young, athletic, good lifestyle, are they more likely to get better from a bout of lower back pain than someone who's older, someone who has lots of comorbidity, someone who has poor lifestyle, etc.? I would have to say, based on the data that we have, absolutely. So it's very, very hard to generalize recovery in terms of natural history or prognosis. And it's also quite hard to generalize the effects that people are going to get from treatment. And I think that's why clinical practice is about understanding the patient better, understanding a little bit more about them, understanding about their ecosystem, understanding about their history, etc. I think that's really important. So why don't we talk about some of these factors that may influence recovery? So they did a great paper, Chen 2018, looked at some prognostic factors for recovery and trajectory of lower back pain over 5 years. One of the things that they found was that higher pain seemed to be a prognostic factor. So the higher someone's pain, the less likely they were to get a large amount of pain relief or a large amount of recovery. And we could say that probably boils down to a sensitized system. If someone has a sensitized system, changes within their nociceptive functioning or changes within some of the perceptual elements or whatever other part of the pain system, I know, shoot me, that we're talking about, are they likely to have the same responses or same level of endogenous analgesia are going on or inhibitory mechanisms, etc.? Probably not. I think that's really important to understand. So the longer someone has had pain and the higher their baseline pain, the less likely they are to recover over a period of time. And I think that probably reflects the severity of the problem and probably reflects how much change might be happening within their system. Those kind of plastic changes that happen at multiple levels of the nervous system. So we may have causative factors for painful problems, but we might also have maintenance factors as well. So maybe the longer pain goes on for, causation is much more about these maintaining factors or adaptive factors within the nervous system rather than simply what is causing this pain or pathology or a nociceptive driver to be cut out or, whatever else. So I think that's really important. One thing that they don't measure is irritability because it's really hard to measure. But high pain, I suggest, would be also accompanied often by higher irritability as well, just showing a heightened function of all that nociceptive stuff going on. I think that's really important. So multi-site pain, that would be another thing that's often prognostic. I think over 4 pain sites has been shown to be prognostic of longer duration of pain or more sticky symptoms, if you like. And again, that makes sense. That probably shows it may be more systemic rather than localized, whether that could be autoimmune, whether it could be central functioning of the nervous system. I don't think we know, but certainly it shows potential plastic changes within the nervous system that may be less likely to unwind as quickly as some other, maybe simpler, I hate that terminology, but maybe less complex problems that we might see. Lifestyle. Again, how does lifestyle and health affect pain? We could talk about, does it create systemic inflammation? Does it have other effects on our nociceptive functioning? These are kind of risk factor elements. We don't know exactly how that works. It could be behavioral. It could be, lots of different things, epigenetic. But poor lifestyle, smoking, drinking, sedentary behavior, obesity, which could also be suggested as a comorbidity. These are things that definitely influence whether people get better or do not get better. Again, they probably don't always cause injury or pathology. That would be like an inciting event, but maybe they have a maintenance factor, maybe they have a risk factor element within there as well. So that would definitely be something that I think would be prognostic and would say, how likely is my patient to respond very favourably to treatment, or how likely would it be that their pain is going to go on for longer than average. Comorbidity, we know that comorbidity can predict chronic back pain and also the severity of chronic back pain. So the more comorbidities we have, generally the more sticky painful problems can be, and that might be things like high blood pressure, might be things like high levels of cholesterol, it might be poor metabolic health, It might be other comorbidities, diabetes, for example, and all these things, again, seem to have a kind of systemic effect that influence recovery and influence whether people get better or not. There are also risk factors. Again, do they cause problems? Maybe. Is there maybe something added into the fire, like, some kind of nociceptive insult that then goes haywire and gets out of control? I don't know, potentially, possibly, maybe. But certainly we know that these things are influencers of musculoskeletal problems. Let's take frozen shoulder, let's take carpal tunnel. We know they're heavily affected by diabetes. We know that hypertension affects back pain, for example, very, very common comorbidity, and may be reflective of, again, the health of the system. So lifestyle and comorbidity may be reflective of the the kind of state of our human ecosystem, and they certainly seem to have an effect. Can we simply treat them? Are they treatable? We don't know. Would it make sense maybe to try and clear or clean some of these things up? I think absolutely. But we also have to acknowledge that lifestyle change is very difficult. Comorbidity, again, really, really difficult to manage, and again, might be out of the kind of MSK realm a lot of the time. That would be more kind of medical intervention and drugs and these type of things, but they are definitely going to influence whether my patient might get better or whether actually nothing happens, or even why they may get worse in response to some treatments. Now, we have things like activity levels. We could, again, probably put that into poor lifestyle. We know that people who are more active don't have as severe lower back pain, have a lower incidence of lower back pain. Again, look, we could discuss why that happens. We could discuss the prevalence of that. But certainly I think there's a fair amount of evidence out there to suggest that occurs. And then we have the psychological factors. I think we have psychological comorbidity such as depression and anxiety. Do they have a great connection with nociception? I don't know. Are they about habits, or are they about how we might encourage poor lifestyle and these type of things, So I'm not always sure the link between psychological factors and painful problems are purely through the nociceptive system. Maybe there are elements of perception of pain, or perception of the gravity of the problem, and then also behaviour as well. And then there are some other things that seem to be quite strongly not prognostic maybe, but mediators of treatment. For example, things like pain self-efficacy. So pain self-efficacy would reflect our belief in our ability to do things with pain, and that probably reflects how we perceive pain as kind of damaging or threatening versus being uncomfortable and painful. And we kind of need to take notice of that as well. Pain self-efficacy does seem to be a mediator and a bit of a prognostic factor. I think Rachel Chester's done a lot of work in that space within the shoulders, and we see that pain self-efficacy predicts some outcomes greater than fear avoidance, greater than depression and anxiety, because it probably affects our behaviour. If we feel more comfortable with having a little pain, we might be more likely to engage in positive behaviours, and therefore we might be more likely to do things that are positive for our painful problem. But really, it's about getting to know who our patient is, getting to know some of these factors that might be indicative of someone responding well or favourably to a treatment, or someone having a better prognosis. Again, these things are not just static. A lot of research is about averages, and it's about finding out, is my patient more towards one end of the bell curve, or do they sit in the middle? Because even an average, it has a middle, and there are outliers within that bell curve. And it might be my patient is towards the positive end of that bell curve, or it may be my patient is towards the negative end of my bell curve. And again, that might help us set expectation. It might just help us understand why someone isn't getting better, or where maybe to focus in addition to our manual therapy or our exercise. But there are lots of reasons why people don't simply get better. First one would be we don't have many averages, even though we have lots of averages in research. People have their own individual prognostic factors that's going to affect their prognosis, might affect their response to treatment. And it's important that we understand that from a research level, and then important that we understand that from an individual level as well. I hope you've enjoyed that little dive into why is my patient not getting better. It's not unusual to get it completely wrong and people recover even though they have all these prognostic factors, or don't recover even though they have positive prognostic factors going on as well, because it's the human body. There isn't always a rhyme or a reason. We have the Core Kinetic Mentorship upcoming 23rd of September. If you are interested in getting into some of this type of stuff, not being simple and reductionist and Instagram about it all, you actually want to learn some kind of a bit deeper, appreciate a few more factors that might influence recovery and influence treatment and what you can do about those, please check it out. Come join us. Drop me a message, ben@corekinetic.com, COR-KINETIC.com, and we can chat. Hope you enjoyed it.